So, Lisa, why don't you tell us a little bit about what you know about the COVID-19 pathophysiology and the kinetics of infection and how that might compare to other types of viral illnesses?
Well, I think we've learned so much from the very beginning, and that learning curve has been exceedingly steep as we take care of patients and learn from our colleagues in other countries too, as well. I think it's interesting when you contrast COVID 19 to influenza that we dealt with commonly on a seasonal basis. And we were used to influenza with an incubation period of 1 to 4 days, infectious period of anywhere from 3 to 7 days. And now we're faced with a virus where you can shed it like others before you become symptomatic. Most people have symptoms by about 5 days, but the incubation period can range from 2 to 14 days, hence these long quarantine periods. And that early week or so, we had those peak and viral loads. But the second phase with more severe illness that usually requires hospitalization, treatment for hypoxia, even critical care is likely a result not so much of viral load, but inflammatory cascades or so. Um, what are your thoughts on that?
I absolutely agree with you. I think the damage has been done already by the virus by the time they get to the hospital. And so that the lung injury takes a life of its own. The inflammation starts causing more lung injury and continues this cascade of progression towards ARDS for some patients. And so, therefore, we really want to aim early on when we identify these patients and treat them as early as we can with whatever we have available. And an analogy I oftentimes give people is if you had someone come in with pneumonia, you wouldn't wait to treat them with antibiotics. You would start the antibiotics immediately because you know that if you have someone that's untreated, they could potentially lead to sepsis and potentially even ARDS. And so that's why we really want to identify them as early as we can when we have an opportunity to intervene on that virus.